Hello, welcome back to my IVF and the European Fertility Society. We are back with another topic and another expert right here. Dr. Kozyra is with us. Hello, thank you so much for joining. This is your first webinar with us, and I'm really happy to have you with us. I hope you are all well and are ready to discuss this topic today. How are you feeling today?
I'm fine, thank you very much. So it was a busy day, but finally I was excited every day, all this day, because I waiting for our evening event and really want to speak, to share my knowledge, and have a good communication, good success, and produced.
Thank you so much indeed. Please let us know that you can hear us because someone wrote that have some issues with hearing us. So please let us know if this is just one person. Okay, thank you so much, Victoria. So if you have any issues, please refresh, and it's best to use Google Chrome for this. Some other browsers have I had issues with them. So if you can switch, it would be great. And let us know if you can hear us. Thank you so much for confirming. I think everything is fine. So before we start, let me just briefly say that Dr. Olexandra Kozyra, she's the gynecologist, reproductive specialist, of course, at Fertility Clinic in Lviv in Ukraine. And the clinic is called Alternatyva. So I'm really happy to have you here. And we will be discussing IVF failure and how to make it successful. So as always, we will start with Dr. Kozyra presentation on our topic, but afterwards there will be time for your questions. So remember to put those in the chat, and Dr. Kozyra will definitely try to answer all of them. So don't hesitate. We are simply here for you. Remember, it's recorded. It's all anonymous, so you can freely ask anything that's on your mind, and I'm sure we'll do our best to answer and help you as much as possible. Please remember to provide some details, of course, but remember that this is not like one-on-one consultation, and I'm sure Dr. Kozyra definitely needs a little bit more background to provide you with a thorough answer. But of course, feel free to ask anything that's on your mind. And if this is something that is really complicated, I've seen it many times, there will be always a chance for you to simply directly contact the Clinica Alternatyva and her team, and I'm sure they will be able to provide you even with more details. All right, this is just for the beginning, but I think we can go ahead with the presentation first, and as I mentioned, we will take care of your questions right after the presentation. Yes, are we ready for the presentation?
Yeah,
Perfect, thank you.
Thank you very much for the kind introduction. So my name is Dr. Olexandra Kozyra, and I'm IVF specialist. I'm not so far away to define my PGD work. It was about the uterine factor of the infertility, and including the window of implantation of the receptivity of the endometrium. So my professional experience 40 years already, and then from the IVF and infertility area. So this is the three reasons why I'm here and why you will hear me today in the evening in this beautiful holiday time. So I declare a conflict of the interest in the preparation of this lecture. And first of all, let's start from our topic, unsuccess attempt, and what we think about when we speak about the unsuccess attempt. We speak about firstly about the bad luck in the cultivation when we cannot receive after the IVF cycle the embryos. The second one, it is about the unsuccess embryo transfer when we cannot get the positive ACG test, and the third one, it is failure, and it is the loss of the pregnancy in the early pregnancy term or in the later pregnancy term. So all these cases can be discussed today, but during the preparing of this presentation, it is very wide topic actually, and it will be any like a concrete information percentage or any marketing information about the very success methods or some farms medicine. This topic about the puzzle, and puzzle, it is the case, about the course, why it can happen, and how we can fix some problem during our IVF attempt. And it is between my experience and between the evidence-based medicine. It is between the psychological and the clinical efficiency. So it is about the possible puzzle from some we can make the picture and understand why your unsuccess attempt can be felt actually. So what is the common reasons of the IVF failure? And the first and the most important, like evidence medicine tell us, it is the embryo quality issues. So it can be some chromosomal abnormalities and the picture of the poor development of the in the cultivation. And our many research tell us the 16% unsuccess attempt. It is about the embryos, about the aneuploidy, about the bad quality of the embryos, and actually the potential to reach the pregnancy with this kind of the embryos. The second factor, according to our statistic, about the quantities, about the rate in unsuccess rate, it is uterine factors, and a lot of the possible factor there actually in this group of the factor. It is about the issues with endometrium lining, it is about the polyp, it is about the adhesion, it is about the bad receptivity of the endometrium, wrong answer for the hormonal stimulation or own hormonal levels. Also, it can be uterine abnormalities. It's also it is divided for congenitals and acquired uterus problem. So it can be like a uterus abnormalities of the shape of the uterus, and also it can be something which come to your life during your life. Actually, it can be the fibrosis, fibromyalgia, etc. The third factor, it is age-related factor. It is about the decreasing of the ovarian reserve and the poor embryo quality. But this third group of the factor is really very related with the first group, with the embryo quality issues. And fourth, it is the sperm factor. And from the data of the scientific public and from my experience and my scientific work as well, the poor quality, the bad luck with the motility and with the percentage of the normal morphology is correlated with bad luck with the cultivation, and from the cultivation until the live birth rate as well. And the last of this group of the factors is immunological factors. The last but not the last according to the offering, but not the last in the importance. It is the immunological factor, and all, of course, it is unknown factors, and it can be divided for something that we can catch when we screen you, but we cannot catch it on the first screening, for example, or after first embryo transfer. And the second group of this factor, it is something which can be not checked and cannot be screened right now on this level of the development of the medicine and IVF area as well. But let's go ahead to the strategies over the IVF success, how we can improve. And this first group of the factor, it is about this kind of the unsuccess attempt when we cannot reach the embryo after the cultivation, after the stimulation, superovulation, egg retrieval, ICSI as well, and in the end of the cultivation we cannot get the embryos as well. So how we can fix it? The first and the most important is customize the protocol according to your experience, because you already stimulate this, your doctor already stimulate you, and understand what is the bad luck during the stimulation, what can be fixed, maybe it can be some stimulation medication can be changed, maybe some additional medication like LH hormone can be added, or something like this. Also, it is important to understand the reaction of the trigger, because we have the couple type of the trigger. It depends what it was used in your own stimulation and what was reacted, what is the maturation rate, was the index between the follicles and oocytes which were reached after the egg retrieval. And with all this information, it is a high price for this attempt, but anyhow, a lot of the information can be taken and can be used in the next protocol. And I cannot tell you that I know the patient who cannot be accepted for the second protocol after the first failed protocol in the IVF attempt. Of course, the supplements should be used, and we cannot tell that some happens, something can be changed in the deeply different way, but anyhow the DHEA and coenzyme Q10 can be taken and can improve the quality of the oocytes, but you need to take these medications from the 1 to 3 months at least between the next stimulation. Also, it is about the improving of the embryo quality. It is about the covering of this kind of the unsuccess attempt when we cannot get the embryos, and it is about the some type of the program when implantation were failed. So how we can fix it? Also, of course, the pre-implantation genetic testing (PGTA) can help us to get the right embryos on the first attempt, because you need to know anyhow. It doesn't matter what is your age on the day of the egg retrieval, but you cannot have the 100% of the euploidy embryos. It is really some miracle, and the world statistic told us that anyhow at least 15% of the embryo will be aneuploidy in any age, and this percent will decrease from the year to year, and extremely quickly from the 35 till 42 years old actually. So the PGTA can help you not only the understand do you have this euploidy embryo as general, but can be saved you from the unsuccess attempt. So as soon as you find the right embryo and make the embryo transfer, your chance to get the pregnancy increase very strong. Of course, timeline imagining of the embryo selection can help us. And in the case when we have the poor outcome from the cultivation or unsuccess attempt, and we have another one cultivation, it is really nice decision to check the cultivation of the embryos. And right now we have a good evidence medicine base which tell us how we can find the right embryos and how we can choose the better embryos according the kinetic of the embryo development as well. So, and if anything can help you, for example, if your biological material have a low quality level actually, or you cannot reach the euploidy embryo from your cultivation from time to time, you need to think about the egg donation or sperm donation if it is needed, according your like a personal clinical indicator. What I can tell you about the uterine receptivity, it is very important test, but you need to think about it after at least 2 unsuccess attempt with good quality embryos. I cannot tell you that it is about the euploidy embryos, but good quality embryo. 2 unsuccess embryo transfer give our some additional thinking about that something wrong with your organism, and the question not only about the embryo. So the hysteroscopy and evaluation of the shape of the uterus, the endometrium lining, and sometimes we can check during the hysteroscopy the pathology When we cannot catch in the ultrasound diagnostics, and it doesn't depend actually, depends on the quality of the ultrasound machine which we use, but sometimes it happened, you cannot find something in the ultrasound, but as soon as you go for the diagnostic hysteroscopy, you can find some pathology, and after the removal on it, it can really help us. So error test, it is something which you can do at home, and in Ukraine it is not so wide and routine examination, but we have another variants of the evaluation of the endometrium receptivity, but in Europe and in the developing country like US and like the UK, Australia as well, you have a lot of these variants of the tests for the endometrium receptivity. There are different numbers of the genes and the different like view of the result, but anyhow the main idea about the test to catch when will be the best time of the receptivity of the endometrium, and if it is not like in the common period, your embryo transfer can be shifted on this time when your endometrium receptivity is the best, and it is really can help you if it is really your case actually. I was on the conference in the United States. It was ICRM 2024, and I hear the very beautiful, really beautiful oral speech about the error test from the Sweden colleague from the Sweden, and she showed their own statistic in which they show that actually error tests cannot improve the um, success of the treatment of their patient in their like routine practice, but to be honest, they make this error test for like routinely for all patients who has at least one unsuccess attempt. It doesn't depend, it depends on the euploidy of the embryos. So when you have this kind and this kind of the group of the patient who uses test, it really will not looks like efficient. But if you have this kind of the patient who has the unsuccess attempt with the euploidy embryos and with the covering of any other issue, it really can help us and find this problem. Also, it is about the optimization of the endometrium sickness, because the thin endometrium, it is a huge problem in the IVF area, and a lot of you know about it, about how difficult to make this endometrium sicker. And we have some like kind or some procedure which can help us and our patient to reach endometrium sicker, and with any additional millimeters and a half from the millimeters from the 5 till 7, the success rate is decreased very strongly. So if you have this problem with the thin endometrium, it is really time to find the opportunity to give possibility this endometrium grow a little bit more as well. And also it is about the screen of the extragenital factors of the implantation failure. So it is about the immune factor, and in Europe we have you have a very nice test which is name is Chicago. So this test can show the problem with the NK cells groups, and in the same moment show us what the medicine can help us to work with this level, and to give a possibility of your embryos to be implanted with your uterus. So a little bit more about the endometrial and uterus, because it is very close topic to me, because if we speak about the euploidy embryo, it is about the embryologist, but if we speak about the uterus, of course, it is from the gynecologist and from the IVF specialist. It is something which we carry out by ourselves. So the first one, it is optimizing of the endometrium. the first line in actually, this is the take a right decision. What is the protocol? The endometrium preparation should be choose by you. So should it be the natural cycle or artificial cycle will work with you in the best way. And also we need to think and to remember about the long and ultra long protocol of the preparation. And it is good enough for the patient with the huge and very difficult pathology like endometriosis, endometriosis, etc. But if you don't have a normal, if your endometrium didn't react to the normal level of your natural hormone, you need to go to their artificial cycle as well. But in this case also you can have a different reaction for the different kind of the medication. And in this case the change of the medication can help you as well, and change of the dosage can help you as well. Of course we need to think about the using of some specific methodology to improve the thickness of the endometrium. So placenta-rich plasma and using of the factor, granulocyte factor of the growing can help us to make your endometrium thicker, like we discussed in another previous slide. Also the treatment of the uterine conditions, polypectomy, myomectomy, adhesiolysis can help you, of course, and can be a good treatment for your unsuccess attempt as well. And we don't need to forget the chronic endometriosis. And what you need to know about the chronic endometriosis, this is some kind of the pathology which cannot be absolutely a reason of your infertility or your unsuccess attempt. But anyhow, the cohort of the patient who has a who has the endometriosis and incurable endometriosis. So you didn't get the right treatment from this pathology, the unsuccess rate will be higher, and the risk to lose a pregnancy in the early pregnancy term is higher as well. Also, let's speak about the immunological factors. The role NK cells in the treatment is huge, and it is something which you need to know about the treatment in Ukraine. And I really have I don't know, maybe near the 100%, 100 patient from the last 5 years, which come into Ukraine only to get the treatment with the IVIG, because not in all country this kind of the treatment are in law. So we screen it very successfully, and we know what should we do with this kind and this factor of the unsuccess attempt. So I really need to start from my explanation of my specific of my work. So as soon as I was accepted like the IVF doctor, I start to work with the patient from abroad. So I start to work with the patient and continue to do it now. All my patient from the start were the patient from the with the unsuccess attempt, because any patient from another country will not come to another country for the pure IVF treatment. So at least two unsuccess attempt my patient has, and coming to me to understand why it didn't work. And like it is my knowledge when I can share with you today. And I know not only about the clinical aspects of this treatment, but I know as well how I need to optimize the time of the patient who coming from another country, and how I can optimize their screening list and their financial and their time as well. So it is one of the point. It is about the immunological treatment, about the immunological screening. And how you can be screening at your country and how we can use this screening in the treatment program and treatment plan in Ukraine as well. A very important factor, it is also the genetic consideration in IVF. So it is not only about the aneuploidy embryo, it is about the case when you cannot reach euploidy embryo at all. Or if, for example, some of the patient is a carrier of some monosomical diseases, so you need to know that the genetic condition can be an issue of the unsuccess attempt as well. That is why actually I'm in my clinical practice. I think not only about the statistic, but I think about my patient as well, and I use the PGS diagnostic not only like a um, um, treatment or screening option for the patient from some kind of the group with the problem of the genetic, with the advanced maternal age, but it doesn't matter what is the age of my patient, but anyhow, if I have more than 2 embryos, I ask them to make a screening of to the aneuploidy to give them possibility to find quickly the euploidy embryos. And in this case, for example, if we cannot find the euploidy embryo from this spot, we saved our time and our psychological like a condition uh, to avoid this unsuccess attempt. But in this case, we can understand and catch this factor of the unless of the euploidy embryo at all. So this is very important point. If we speak about the monosomical diseases, it can be a reason why your IVF attempt can be unsuccess. And in this case, you need to know exactly what is the kind of this disease, how you can you check it. In this case, anyhow, your partner should be checked as well, because if you are a carrier of the monosomical diseases, to avoid to have a baby with the same problem, you need to make the PGS diagnostic of the embryo. So in this case, our next generation screening can help us as well. So you need to think and to know that it is not so important what the age category you are. It is important to catch your euploidy embryo and to make the embryo transfer with the right embryos. And also, if you know about the monosomical disease, or if you want to screen it, because right now it is a lot of the option and a lot of the laboratories who can do it for yourself, and you understand what you are carried actually and what is your partner carried. In this case, it is good chance to avoid a problem with the child in the future. But let's go to the very difficult cases of the unsuccess attempt, and the first and the most important. It is the second point in my presentation, but actually it is, I think, something which I need to tell you and which you need to know. It is about the mitochondrial donation, and who can be considered for this kind of treatment. Actually, it is the patient who has a good rate of the fertilization but cannot reach the blastocyst in their own cultivation, at least in 2 and better in the 3 protocols. So in this case, this kind of the treatment can help you reach your own embryo with your own chromosomical kits from you and from your partner. So it is not a topic of our event today, but I tell you like in the huge detail. So it is a technology when in your zygotes, this is the embryos on the after the fertilization, then the first day of the cultivation, and in the oocytes cell you actually have not only one nucleus, not only nucleus from the oocytes, but it is already fertilized but nucleus from the spermatozoid, and you have in this, like, you have the embryos, and it is two nucleus from the oocytes and from the spermatozoids. And in this stage of the cultivation, these two pronucleus which are fertilized take off from your own oocytes and put to the oocytes from the lady donors, which were fertilized before. And it is like a changing of this pronucleus from your own oocytes to the donor oocytes. In these cases, in this case, you have a chance to have your own chromosomical kit, but develop the embryos in the good quality of the environment in the donation oocytes. So it can help the patient. And I had. I was happy to treat the patient with this kind of the technologies, yes, and we really, it is not something which has a success rate like a 100%, and not like for 50% as well, because a different kind of the patient were included in this type of the treatment. But we really have the babies from these technologies, and we know them, and it is a very difficult. It was really very, very, very difficult patient, but it is something between the egg donation problem, pure egg donation program, because anyhow you use donor eggs, but you can use your own biological chromosomical kits from your own oocytes. Also, artificial intelligence in embryo selection will help us, and it is something which I already started to tell you that and now it is not only about the time lapse, it is about the like selection of the oocytes, selection of the spermatozoids. And if we speak about the selection of the oocytes, it cannot help us as very strong, because we have a limit number of the oocytes anyhow. Let's take, for example, a most hyper responder. So we will not have more than 50 oocytes, for example, mature oocytes. But if we speak about this sperm sample, we had a lot of the spermatozoids in the most part of the case, yes. And we need to find a good quality of the embryos, but we cannot do the spermogram, we cannot check the morphology, we cannot check the DNA fragmentation as well. So we can only choose the spermatozoid according to his condition, morphological condition, and according the kinetic position, about the motility, etc. But if we speak about this IVF artificial technology, it can help us to choose the system coach, this artificial coach about the huge evidence based, and to tell us, look, this spermatozoid, according his parameter, according his kinetics, this is the best one, and you need to choose this one to fertilize your oocytes. So these technologies, and a lot about this artificial intelligence, it is really not the topic of my presentation today, but I need to share with you this information as well. And also, it is not some modern type of the IVF treatment, but it is still help some population of the patient, some cohort of the patient who has this very strange problem, like immature oocytes. So in vitro maturation can help the woman with PCOS avoid the ovarian hyperstimulation and avoid to have the bad KPIs of the oocyte fertilization and cultivation as well. And if your unsuccess attempt related with this low level of the maturation or low level of the fertilization, or maybe it's the reason of your unsuccess attempt. This is the syndrome of the empty follicles. This kind of the technology can help you as well. And now I want to speak with you about not about some like very exotic kind of the IVF treatment or some modern methodology, but it is something very basic, but we have a huge change in from the between the biological material before and after this modification on the lifestyles. So what you need to know, and you can check here what I want to tell you about you and about your partner and why it is so important. But what I want to share with you, that the normal balance time between rest and work, the normal timelines when you need to wake up and when you need to lay down and when you need to follow and sleep, about your what you eat, about what you drink, how often you do it. You need to give your body to feel that it is in the rest and it is safety, because as soon as you stretch your body with a different kind of the stress and get off the some kind of the eat, of the drink, of the rest, as soon your body feel that you are in the stress. But the body in the stress, it is don't want, and it is like something natural and physiological mechanism to avoid the pregnancy, because the body in the stress, the organism and the stress, it is it, it is general needs to run very fast, to breathe very deeper. So it is not about the pregnancy. So what you can, how you can help you in the best way, you need to give your body as bad as you can in this, and you will be really very uh, um, very happy to understand and to find your answer of your body in the better way as you see it before. And something about it addressing of the psychological challenges, and because all of you here, you are here because you already have this unsuccess attempt, and your like a journey, your patient journey in some time of it is destination becoming this kind of the stage. And anyhow you have the stress actually, and it is something, it is some very deep and some very dark place from which you need to go away. And it is about emotional, it is about the support, it is about the partner and the people around you. So how you need to continue, how you need to get off your head and to breathe and to go away. And it is something with which I work with my patient by myself as well. And actually what you need to know about our organization of the IVF treatment and support, we have another tactic and another strategy. We in the close relation with our patient and the close communication, and our assistant mostly help us to organize some documents issues, maybe financial, prepare the financial documents for the patient as well. But we are we are in the communication with our patient 24/7, and we have a lot of the consultation after unsuccess attempt. Of course, we have in Ukraine the psychological counselor who are specialized on the this perinatal follow attempt and failure. but something we do by ourselves, and what can help you to carry out it is the communication with the patient, with the psychologist, and with your doctor as well. And this year I create the Telegram channel when I add my patient, all my patients who are very close to me, and uh, they agree to share their personality, and now all of us communicate there. And I like it was my strategy to add there the patient who already gave a birth, who are pregnant, who are in the active stage of the treatment, who are not in the first time treatment, who is in treatment in the first time, and who take a decision to go to the IVF treatment as well. And all of them communicate there and help each other. Of course, they communicate there when I'm not there as well. So it can help them. They share their experience. They explain and write there how they feel themselves on this moment, how they can uh, carry out actually. And it is really work, and I hope that I have this kind of the patient who are so kind and so polite to share this information and help next one, and after that this next one help the next one. So it is not only about me, a lot of the chat, a lot of the communities of this patient there are, so you can like be involved there and take support and take care there as well, and it really helps. What I actually think a lot about the information what I can share with you, and it is something which I took a decision 1 year ago. I have like a professional profile in the Instagram, and there at least one at month I tell my patient success and I success IVF stories of my patient, my own patient, but it is some kind of the story which they need to hear really, and from which they can take something interesting and something important, and coach themselves with this topic. So for you, I want to share two very short stories today. The first case it is about improving IVF with PGTA and frozen embryo transfer. And you think right now maybe uh, that we reach the euploid embryo and get the success attempt, but not. It is not about it. About this, it is about the patient who had very young patient actually, both of them, and they are the factor of their infertility what the tube factor. So like this is absolutely factor of the infertility to be considered to the IVF treatment. But we get the 4 embryos. We didn't make the PGTA, and all of this, all the attempt were failed. So we go for the next IVF treatment, and on this stage we already make the PGS diagnostic for the 2 embryo from 4, and both of them was were aneuploidy, and we take a decision to worm 2 because both of them was the normal quality. We take biopsy from them as well, and we was shocked when we get aneuploidy embryos as well one time more, and we understood that it was a high risk that the first cohort of the embryos was with the problem as well. We we went to the genetic counseling, and it was they find the problem with the chromosomal kids, and we go ahead to the egg donation problem because it was very low chance to get the health embryos with their own biological material. Both of them was with some kind of the mutation, both of the patient, but we reached the pregnancy with the egg donation program from the first attempt. And but the question how long we continue this we could continue this kind of the treatment in case if we didn't make the PGTA this young patient. So it is my first story for you. It is something which are not like absolutely happiness, and it is not something which all of the patient can consider from the first time, but it is about the success story, and we need to know that sometime we need to pay this tax for it. And the second case, it was really a long time ago. This patient was treated by me, but this sorry. And the second case it is about the success pregnancy after addressing of the endometrial issues, and it is about my very close person with whom we start to treat her infertility 7 years ago, and she reached her pregnancy not so long time ago. Now it is 27 weeks of the pregnancy. And how it works, we had the two IUI with the sperm of the partner, and it doesn't work actually, and her factor of the infertility was unknown because everything was okay. Like in general, something was wrong. So the shape of the uterus was not like ideal. The quality of the sperm of the partner was not like a normal. Some deviation was from time to time. But we go from stage to stage, and on 2020 we make the first IVF program. We didn't do the PGTA because there was a young patient actually, and we make the first time embryo transfer. It was failed. The second time it was failed, and third time third embryo transfer were done not by me, but previously the doctor. I was in my maternity leave actually, but the doctor who take this patient from me, she told that we really need to make the hysteroscopy, and because of the shape of the uterus, and on this time the classification of this uterus abnormalities was changed, and her uterus accepted a uterus with the shape which should be changed, and they have the success attempt actually. She implant the embryos, but before the 6 weeks of the pregnancy, it was a miscarriage, and I was in shock a little bit, and she as well. But time go on, and we take a decision to make the embryo transfer with the two last embryos, and we prepare all. We check the chronic endometriosis. We make the hysteroscopy, like a diagnostic hysteroscopy. We check the problem with the whole coagulation system, etc., etc. So we go ahead and with the make embryo transfer, and it was unsuccessful once again, and we understand that we need to go and to make the embryos once again. But I told her, because already 2 years go from the first hysteroscopy, and the metroplastics, and the uterus shape was looks like previously actually, and I told that we really need to make this procedure once again, and we make it in the June or May, and after that she had 2 months of the replace hormonal treatment. And on the third month, actually, we should go to the IVF treatment and to make the embryos once again. But she told me, Sasha, I cannot really. I think that it is which can help me actually, and I'm not sure that it can help us. And she go for her normal menstruation cycle, natural menstruation cycle, and I ask her to come to me for the 3D diagnostic of the uterus shape to understand what we have after our hysteroscopy. And I find there the really good thickness of the endometrium, the yellow body, and I waiting her. I'm waiting her on the start on the her menstruation cycle, but it didn't start it actually, and she get pregnant in the same cycle. So her true infertility factor was this uterus shape, abnormal uterus shape. And actually, as soon as we carry out, as soon she get a pregnant implant, and the like her pregnant continue right now, and I really hope that very soon we will have a delivery, and I can tell you more about this story. So what I want to tell you actually with these two cases, that individualization care, it is the key of the success actually. And when I sit with my patient and discuss why the previous attempt was unsuccess, it is something individual. It is not something which can help all or can anyone. So come back to the second story. If we speak about the abnormal uterus shape, evidence medicine told us that this factor, it is about the like losing of the pregnancy. It is not about the like primary infertility, but in the case of my patient, it was like a factor which can like a solving of which can help us to get a pregnancy. So IVF is a journal, it is not a rate, and we need to think about how we should go and what is the right way, what is the right branch in your own case. Success often requires perseverance, and every attempt bring you close to your dream. You need to think about it. You need to be sure that it is a true way. Also, I want to speak with you about the role of the IVF team, because all staff and all person who work with you during this like a way, this people is are very important. So embryologist, and like basically you cannot find this person in the clinic, but it is a very important person, and from their experience really relate the quality and the like the outcome from the cultivation. The IVF specialist, it is like I want to tell my patient, I'm not only a doctor, I am a manager as well. So I understand who should be involved in your treatment, from for who from who you should be consulted as well. So and finally, this doctor take a decision who can help you and who should be involved and what is the kind of the treatment is the best one for you. And also the counselor, it is someone who supports you, your psychological and treat your psychological deviation, and etc. So our conclusion, sorry for the long presentation, it is really all information which I want to share with you. I hope we can give an answer for all our questions. So call to action together, let's turn challenges into the success stories. Also, I want to leave there the information about myself and about my clinic and how you can contact us, me directly on my clinic as well. So I'm really happy that you can be there with me from this 55 minutes, and I will open for your question and kindly ask you for the Q&A session.
Thank you so much, Dr. Kozyra, for your presentation, thorough explanation, lots of details and lots of important things that we all need to remember about when it comes to fluid IVF treatments. And as you can see, plenty of questions are right here already. So let's get to them. We have around 15 minutes for the questions. So if you have anything else that you would like to add, go ahead, type those in. And the questions are ready. Let me just start with the first one, which is, excuse me, quite a longer question. So I will display this for you so you can see it. So I'm 35, endometriosis 3, stage 3, endometrioma 4-5 centimeters, diffuse mild adenomyosis, AMH is H. I had 2 IVF cycles, first 2 embryos, second cycle 7 embryos, 15 M2 oocytes, until now 6 transfer in total, genetically untested. 1 MA, 6 weeks, 4 negatives, 1 anembryomola, partner is 39 and has teratospermia, karyotype is okay, immunology only immunoglobulin G deficiency, last transfer with IVIG substitution, minor hematology issues, last cycle added heparin. Not this year, but anything you can advise.
First and most important to
Yeah.
make the screening of the embryos for aneuploidy. So you already have a huge supplements in your treatment like IVIG. It is a difficult medication and very expensive as well. So you don't need to take the different kind of the embryos and try to get the pregnancy with any of these embryos. You need to find the aneuploidy embryo and work with it as well. And about your uterus factors, it is very difficult to understand, but it will be nice to find the images or video shot as well and understand where is this fibroids and adenomyosis of the third stage. It is very difficult. It looks like a very difficult situation. So I cannot tell you exactly that you need it, but your patient who can be accepted for the ultra long protocol of the preparation to avoid this bad influence of the hyperestrogenemia, local hyperestrogenemia.
Okay, understood. Before we continue, there is a follow-up, of course, to this question as well. So do I keep failing because of endometriosis or and should undergo surgery or keep on trying? Anything else you can add on this particular part? This is the same patient, of course.
Yeah. So it is about the endometriosis. It depends actually, because the adenomyosis, this is pathological, which are very wide in the clinical options and kinds actually and types. So the surgery can be done for you. For example, it is retrocervical endometriosis, and you can remove this adhesions. It can help you, but if it is some kind of the diffusion type of the endometriosis, it will not work for you. You need to only take this agonist, gonadotropin releasing hormone 2 times, 3 times, and after that, the grow your endometrium with a replace therapy, and it should work for you in the best way.
Okay, thank you so much, Lenka, for your thorough, of course, explanation here when it comes to the details. But of course, I hope that helped you, Dr. Kozyra. Thank you so much for explaining. If there's anything else, let us know. And there's a thank you very much from Lenka here. So I think that helped as well. Quick question, and we have a few of those actually. So which antioxidants do you recommend? Anything you can advise in particular?
So
It's a tough question always.
Yeah, I know this about this top question. It will be nice maybe to have this list like that, because it is any option right now to write the list and the dosage and how long. So maybe it will be nice if I send to my IVF answers like my list, which I prescribe for the patient, and they can share in their next post or in the website as well, or can maybe send you directly.
You can, you can send me a message directly. I'll be happy to forward this to Dr. Kozyra, her team at Alternatyva. I will put my email address in a second as well, so you can have it as well. It's not a problem at all. So any techniques, supplements that can help to optimize the endometrial thickness?
Supplements, unfortunately, no. Anything can help you with the supplements to grow your endometrium more. If estrogen cannot help you, supplements will not work for you. So at least like you need to try non-invasive. I tell non-invasive it is because it is about only like infusion of the uterus cavity. Sometimes it happened, but we have another type of the therapy. It is hysteroscopy with soup and endometrial infusion of the PRP, and sometimes it can help also. But it is, you speak about the evidence medicine. Now it's the stage D or C. You will speak about A, B, C, D.
Okay, thank you so much again. There are a few questions in one question. So here from Victoria, let's take a look. So we have three questions. What tests are the best to check for endometriosis? What if someone only has chemical pregnancy and during that time the temperature rises more than normal? And does egg quality depend on how big the follicle is during the egg retrieval? Is a too big follicle an overmature means bad egg?
Yeah, anyhow, I need to go so one by one.
Yes, of course.
Yeah.
One at a time. I just
So
wanted to
yeah, what
illustrate.
is the test are the best for the check the endometriosis? So you will speak about the receptivity of the endometrium, and you will speak about the like type of the preparing for the embryo transfer. Should it be like a natural cycle, or should it be artificial cycle? We have some immunohistochemical test which can help us. It is about BLC, and this test show us it is like a protest of the some it is difficult to explain like with the normal words actually. So this marker can help us understand is endometriosis or adenomyosis adhesion can still influence for the endometrium. You will have a difficult patient with this very clinical like a share of the endometriosis. Sometimes we use it, but it is not to work with the patient who has this type of the endometriosis, not a clinical approved. So if we speak about only the ultrasound, like ultrasound top of this problem. I don't know, can you do you at home? But yeah, we have it. We check it. Let's go for the second question. It is about the uh, chemical
Chemical
pregnancy
pregnancies, yeah.
during the time the temperature rise more than normal. I cannot actually understand the question in general. What is the some only has chemical pregnancy and during the time more than normal? So is it question about the increasing of the temperature during the biochemical pregnancy? Do you
Possibly.
understand correctly?
This is what I understand, but of course, Victoria, if there's anything that we are missing here, just let us know. Okay?
Yeah, so it should be like a normal temperature. It can be temperature in 7 sometimes it happened, but it is not something specific with which you can check and confirm that you have the biochemical pregnancy. Anyhow, you need to check at least at least the urine test, or the best to check ACG in the blood as well.
Yeah, so I will just go with this follow-up. So during the 2 week time, 2 week, two wait time, right? So during this 2 week of waiting, I had fever and then confirmed it was a chemical.
So can the like a high temperature
Yeah.
have the influence for the failure, for the loss of the pregnancy? Actually, it depends. We need to know what is the problem was why you have this high temperature. Because I really have a patient, but it was not only about the temperature. It was about the very difficult antibiotic therapy, and she lose the pregnancy because of the therapy of this high pregnancy. So yeah, it can have the influence, but the high temperature it depends. So what is the reason was of this high temperature?
Right. Okay. Thank you. If there's anything else, you know what to do. And the last question, does egg quality depend on how big the follicle is during egg retrieval? Is a too big follicle a bad egg?
Yeah, actually, we have like a mainstream and in general. So if we get the oocytes from the follicles more than 21, 23 millimeters, we can have the degeneration changes in the oocytes as well. And also we can I check it and I read it in the literature that if the cohort of the oocytes the like more than 20, like 23, 25, and the like a big number of the oocyte, the general cohort oocytes, like will have this problem of the quality as well. But it depends also. So some patient have the maturation on the 23 millimeters, but some patient can be generate on the 16 millimeters. So it is very individual. So and sometime on with this kind of the patient, they are first and it is unsuccess protocol, but we with this protocol we can understand better how work with them, how read the good biological material from them. But yeah, in general, we have these issues as well.
Okay, thank you. I think that was helpful, but of course, you let us know if there's anything else you would like to know. Thank you, Victoria. And I will go to the question from Victoria right now. There's one more question from Gabriela, so we'll take care of it in a minute. If there's anything else, please, this will be the final call for the questions. There are 2 questions left, and let's have a look at this one. So could the mitochondrial replacement therapy work with 2 oocytes of the same person? Anything you can add on this?
It is actually doesn't make sense why you need to change. If it is your 2 oocytes, some of them will give you embryo and some of them no. It is like a normal. You need to know that in IVF we don't have anything for 100%. We try to collect a lot of the oocyte as more as we can because we need to have more material to create the embryo, at least one euploidy. If we can more, we want to have more to have a chance to give your pregnancy, to have the additional embryo in the case of the unsuccess attempt. At least if you get the richer pregnancy with the first attempt, it is beautiful. But after the first delivery, maybe you want to go and to create the siblings for your first baby. So that is why you need to understand we can have a lot of those sites, a lot of the follicles, but not of them give you the embryo. So and mitochondrial donation, it is about the like a huge changing of the mitochondrial of the another organelles in the cells and the centrals in general, because this your cell, your oocytes, it is something like a base of the embryos to grow and to cultivate till the stage of the blastocyst. After that, this like nutrition is not enough. It is should be implant and get the nutrition from the uterus already.
Thank you so much indeed. And if you are more interested in also mitochondrial donation, we did have a webinar actually today in the early morning on this. So I can only encourage you to go to my Epipensis. You will find 3 of those webinars that we are focusing actually on this particular topic. So you can find out a bit more as well. Might be useful as well. So I can only encourage you to have a look. And possibly, or yeah.
Little promotion from me about this topic.
Yes, of course. We have lots of, webinars on various topics. So if someone is interested in any particular, this topic is definitely a complex one. I can only encourage to have a look. And Gabriela, possibly our final question for today. So the question is here. I am 43, 0.5 AMH, FSH 11, one IVF with my own eggs with did not implant. I take CoQ10, omega-3, NAD, not sure here, glutathione, Akai, it's okay for quality egg. I have 4 or 5 follicles in once a month. I have adenomyosis. What can you recommend anything for a better egg quality, I believe here?
If you reach as soon as you reach the embryo in 40s in your 43 years, first of all, like my congratulations that you in this age really can read the embryos, but in your case it is not enough. You need to find the and check the chromosomical kit of the embryos. As soon as you read the euploidy embryos, you need to prepare yourself for the embryo transfer, because if you make the embryo transfer with untested embryos, the change to have statistic change to have the euploidy embryo in your age category, it is 70%, 30%, for example, yeah. And if you take and make the embryo transfer without the PGS diagnostic, you can have failed, and it is the outcome will not the same 0 0 0, but you lose your psychological potential. You say, because you get the unsuccess attempt from time to time, and it is really very difficult. From my experience, I can tell you that the uterus can implant and can deliver the baby in the menopause as well, but the 60% of the success, it is from the embryos, it is from euploidy, and it is of the quality.
All right. Well, wonderful. Thank you so much indeed for yet another explanation. Gabriela, I hope that helped. Of course, if there's anything else, you can either type this now or you can simply email me. I've put my email address in the chat, and we'll be happy to forward any of the questions to Dr. Kozyra and her team at Alternatyva. Someone is typing, so let's give it a minute. But in the meantime, I want to encourage anyone who would like to ask any other questions to simply get in touch with us, and we can forward your questions, or simply join us. We will be back on Monday. There is another topic. There is another doctor, and we will be happy to have you here. And of course, with any of your questions. And I believe we will finish for today. So thank you everyone for your time, for asking all of your questions. Dr. Kozyra, again, thank you so much for joining us. It's been great to have you. Before we finish, any final words to our audience today?
Yeah. Thank you very much for your time. See you. Bye.
Thank you so much indeed. Hope you have a lovely evening. And of course, as I mentioned, we will be back on Monday. So I can only encourage you to simply get in touch. Go to my events, and all the upcoming events you will find there. If you would like to get in touch with the doctor, you can always email me. My email address is caroline@europeanfertilitysociety.com. I'll be happy to forward any of your questions. So go ahead and do it. And of course, Dr. Olexandra Kozyra was our guest speaker today. Thank you so much for your expertise, and I'm really looking forward to some more events, probably next year, but thank you so much indeed. Have a lovely evening, and speak to you hopefully quite soon as well. Take care. Have a good evening. Bye.
Thanks. Bye.